Welcome to our video on neonatal varicella and herpes simplex virus. Let's get started. Here's a brief overview of the topics that we'll cover. So we're going to start with the neonatal varicella, and we're going to touch on all of these aspects with both conditions, starting with definition. So neonatal varicella, as the name suggests, is a varicella-zoster virus infection in a child less than 4 weeks old, and it's one of the TORCH infections. Remember that TORCH is an acronym that is used to remember the list of infections that can be transmitted from mother to child in utero, and that can be very dangerous to the infant. And the O in TORCH stands for other. It's a catch-all that includes varicella-zoster virus. So as far as this acronym goes, the O is probably the least useful, but O other includes this. Now, as a brief reminder, the varicella-zoster virus is a double-stranded DNA virus, and it belongs to the herpes virus family. Now, it's also known as human herpes virus 3, or HHV3. Now, before the varicella vaccine was available, this virus commonly caused chickenpox in children. It also causes shingles in older adults. And there are 3 ways by which this virus can be transmitted from the mother to the baby. And these include direct contact, airborne transmission, and vertical transmission, which can occur during pregnancy or delivery. Newborns are at risk for contracting the virus if their mothers were exposed to the varicella-zoster virus within 2 weeks of delivery. And babies can also get the virus via nosocomial transmission, especially if it's a premature infant. Now, in terms of clinical features, the child will initially develop a fever and then start developing clusters of vesicles on the skin. And the skin lesions will actually change their appearance over time. So they start out as macules and then progress to become papules, and then to vesicles, and then they eventually begin to crust. A very high-yield thing to know about this rash is that the skin lesions are in different stages of development. This means that on the skin, the provider will see some lesions will be macules, and others will be papules and vesicles, and some will begin to crust. And the fact that the skin lesions are in different stages of development helps clinicians differentiate this rash from another similar-looking rash that we're going to talk about in a moment, the neonatal herpes simplex virus. Additionally, the varicella-zoster virus can disseminate throughout the body and cause a very severe infection, and that can be super dangerous and has a high mortality rate. Now, here's an image of neonatal varicella. So it's important to note that these lesions are in different stages of development. So notice that some are macules and papules. You can also see some vesicles, and some of those will begin to crust. Now, as stated in an earlier slide, neonatal varicella can lead to disseminated infection. And that's pretty broad. It just means that it goes to somewhere in the body, elsewhere. It's not great. But there are just a few areas of the body that you're worried about. So one, the virus can spread to the lungs, causing varicella pneumonia. It can also spread to the brain and meninges, causing meningoencephalitis, or spread to the liver, causing hepatitis. So how do you diagnose this? Well, like most dermatological conditions, you diagnose it clinically, and you actually treat it with IV acyclovir, and you give it to the child in cases of a disseminated infection. For example, if they develop pneumonia or hepatitis or meningoencephalitis. Otherwise, you don't need to treat. Let's do a quick question. A 25-year-old G1P1 female is diagnosed with acute chickenpox 1 day after an uncomplicated delivery. What is the next best step in prevention of chickenpox transmission to her newborn? Well, the next best step to prevent transmission to her newborn would be to give the baby a varicella-zoster immunoglobulin as a form of post-exposure prophylaxis. So, notably, this form of post-exposure prophylaxis is indicated only if the mother develops a chickenpox infection either within 5 days before delivery or within 2 days after delivery. And since this happened 1 day of delivery, then this mother falls into that category. Now, it's also important to note that the recommended method of post-exposure prophylaxis in cases of chickenpox is to give a vaccine. However, since that's a live attenuated vaccine, babies less than 1 year of age are not eligible for it. So that makes the immunoglobulin the only available option. Now let's move on to talk about neonatal herpes simplex virus. Again, we're going to touch on these items, starting with the definition. So, as you can tell from the name, this is an infection of the herpes simplex virus in a child who is less than 4 weeks old. And similar to neonatal varicella, neonatal HSV infection is one of the TORCH infections. And this is where the H in that acronym is relevant. It stands for herpes simplex virus. So thankfully, it's not just one of those other things that counts as that O in TORCH. Herpes simplex virus is a double-stranded DNA virus, and there are 2 types, HSV1 and HSV2. And the virus can be transmitted to the neonate in several ways. And the first is perinatal, and this is the most common form of transmission. This form of transmission typically occurs when the baby comes in contact with the mother's herpes skin lesions during birth, so perinatal transmission. Now, the second is postnatal transmission, which means the baby contracts the virus sometime after birth. And the third is intrauterine transmission, and that occurs when the virus passes from mother to baby in utero. And that one's pretty dangerous, as implied by the torch infection. But fortunately, that form of transmission is pretty rare. A major risk factor for a baby contracting this virus is if the mother has an active HSV infection, meaning that the mother has herpes skin lesions. And that's pretty logical. If the mother has these skin lesions, then that means there's something for the baby to come in contact with and contract. Now, if the mother delivers the baby vaginally, that exposes the neonate to the skin lesions containing HSV. So, of course, increases the risk of infection. So you can think of that pretty intuitively. There's no tricks here. The baby contacts the lesions. Now, neonatal herpes will typically begin to manifest within the first few weeks of life. And the rash is characterized by vesicular lesions that are located on the skin, eyes, and mouth. And it may sometimes be described as resembling dewdrops on a rose petal. In some cases, HSV may spread to the CNS, which can lead to meningoencephalitis, and it usually affects the temporal lobes. And that's consistent with an HSV infection in an adult. When it causes encephalitis, it typically affects the temporal lobes, and you can actually see that on an MRI. So this is the second virus that we've discussed that can disseminate throughout the body and includes the CNS. And just like neonatal varicella, this virus can disseminate to other organs and compromise those. But the big one you want to remember for this particular HSV virus is that it can cause temporal lobe infection and meningoencephalitis. Now here's what neonatal HSV looks like in real life. And notice that there's a cluster of vesicles on the top of an erythematous base. And that actually looks very similar to varicella-zoster. And so it's actually pretty hard to tell these apart clinically. So this brings us to diagnosis. Herpetic skin lesions can be detected in the mother during pregnancy by visual inspection. However, serologic screening is not recommended. And if you do identify these prior to labor, then a C-section is indicated because you want to prevent transmission to the neonate during birth. Because recall that the most common form of transmission from mother to child is perinatal during birth. So that's how we diagnose it in the mother, but how do you diagnose it in the neonate? Well, diagnosing HSV in a neonate is based on recognizing the skin lesions as well as other signs and symptoms. And once you have that clinical suspicion, then you confirm that with an HSV culture and polymerase chain reaction, or PCR. And how do you treat it? Empiric IV acyclovir. Here's a table summarizing the high-yield concepts discussed in this lecture and the previous lecture. And now you have a consolidated area where you can compare and contrast these very similar neonatal rashes. And that concludes this section.